And there are other differences. Highly variable nursing education. A nurse is not a nurse. There are huge variations in nursing education, and therefore in the amount of help the nurse can be in care. Inconsistent drug quality. They have a drug called Badazolam. We have Midazolam. It's a sedative. It's really commonly used. They're so used to these drugs not working when they give them because the batch is lousy that they have a term for it. It's called Badazolam. I've never in my life ever had to question that if the reason a drug didn't work that I administered was because the drug was bad. I figured it was the wrong drug or I needed to switch. That's their reality. Frequent equipment downtime. Sometimes a CT scanner stops working and they have to push the patient across the street in the rain to get a head image. Those are the kind of things that influence the timing of CT scanning. We don't even think about those. But they're important when you do studies there. So realistically, what we're dealing with is a situation where we don't know what we don't know, and they don't know what we don't know. And when we go to do research like this, these things collide. And the they don't know what we don't know happens twice in two different ways. One is that they actually don't know about certain things that we don't know about, like the orphan patients, which were recognized by neither group until we started to pull in emergency department people and neurosurgery. And then there's another way that that can be interpreted, and that they don't know what we don't know because they take it for granted, because it's their reality, and they think it's normal. It's not our reality, but they never tell us about it because it's normal. And that was the inconsistent drug quality. So we actually had to change some of our experimental designs to get drugs that always work. That I had never thought of when I started to design studies down there. And so realistically, what is the answer to this? What are the recognition of the problems? Because we can't help. We can't use studies down there that make further our own understanding, and we can't use studies down there to help with what they can do until we understand these. And I think it's time on the ground. It's working as a team together to come to the understanding of these. We need to separate this. Where should the money go? Well, realistically, despite the fact that I work mostly in intensive care unit and operating theater, it should go in pre-hospital care. We've already heard a little bit about that. But what's the solution from the US and Europe? Well, that's easy. We want ambulances and helicopters, coordinated care, endotracheal intubation in the field. That's a long-term solution. That is not a short-term solution. What they have in Latin America is not a lot of ambulances. They have a lot of taxi drivers. Over 50% of trauma patients arrive at hospital in Bogota by ambulance. And the hospital pays the fare, so the ambulance drivers like this people. And so basically, if you want to do a short-term solution, you use a very innovative thing that Charlie Mock started in Ghana. And this is the kind of solutions that work, that we would never think of, but that work locally. Train taxi drivers in basic life support. Give them the basic tools to do it. Allow them to obtain a new kit when they bring in a patient. Have companies or insurance agencies fund the kit. Everybody has a cell phone, so all of a sudden you have a communication system. When Charlie did this in Ghana, there was a change in the pre-hospital care in over 50% of patients. A solution that doesn't exist in the US, but is a simple, effective, immediately effective solution in low and middle income countries. So basically the question of how should a Latin American physician interpret the literature? Does literature we generate from our own data mean anything to them? And can our solutions be transported straight away down there? Probably not. Probably not. We have to live there and understand this before we can generate anything. And I think the basic statement is that only by the team understanding a separate reality can the team develop solutions that work. And the two key parts of that are, one, the team. You need to spend time with people from there to make it a shared reality. We can bring the research culture to them. They have no research background. They're not trained in school. They get no rewards for doing research. They actually don't know how to do it. We know how to do it, but we actually don't know what to do. They know what the reality is, and they can bring the reality to us, but it isn't something they show you. When you visit them, they don't want to show you their trauma hospital. They want to show you their fancy hospital. You have to get to know them and actually become part of their family, and that's the way they will describe it, La Familia. So before they show you these things, and shoulder to shoulder you walk through the reality of their treatment, and then you can come to an understanding. And that, you can't buy that. That's time and relationships. The second bit is that it's a separate reality. It really is not our reality. it won't even click when we go down there. We think it will. We'll see the things we think that we see every day. But it isn't until you spend time to really understand those that you can actually put something together. Thank you very much.